Assalamu alaikum doctors, welcome to my YouTube channel MBBS NBDS lectures. Today is the second video of rapid revision course of oral medicine, which is very important for NLE exam, MDS, NBDE as well as for PDS students. In this video we will discuss about oral candidiasis, which is very important for NLE because in March NLE exam mostly MCQs come from oral candidiasis. Now, first we start from definition of oral candidiasis. Oral candidiasis is actually an opportunistic infection when our immunity decreases, then oral candidiasis occur, like mostly in HIV patient. Now, oral candidiasis is a fungal infection which occur due to Candida albicans and Candida dublinensis. Candida albicans and Candida dublinensis are the candidal species causing oral candidiasis. This is the definition. Now come to the types of or classification of oral candidiasis. We classify oral candidiasis into two. One is acute candidiasis, second is chronic candidiasis. Then in acute candidiasis there is two subtypes, and then in chronic candidiasis there are four subtypes. First, in acute candidiasis, the first is the pseudomembranous candidiasis, which is also known as oral thrush. Second is the erythematous candidiasis, and formerly called denture sore mouth. See, in chronic candidiasis, the first type is the chronic atrophic candidiasis, are also known as denture stomatitis. Second is the angular cheilitis. Third is the chronic hyperplastic candidiasis, are also known as candidial leukoplakia. And fourth is the median rhomboid glossitis. Now after classification and types, come to the predisposing factors. In predisposing factors, number one is the immunodeficiency. We already known it is opportunistic infection when in immunodeficiency like HIV, oral candidiasis occur. Second predisposing factor is the anemia. Third is the antibacterial drugs being taken over a long time. Next is the xerostomia. Next is the smoking. Next is the high carbohydrate diet. And this next is the nutritional deficiency like iron, folate and vitamin B12. And last is a steroid inhaler. And when we inhale steroids, this steroid also decrease our immunity. In the result, there will be opportunistic infection. And in xerostomia, smoking, high carbohydrate diet, again there will be in the result there will be diabetes, and in diabetes again our immunity become decreased, and the result there will be oral candidiasis. Now come to the detail of these types. First, in acute candidiasis, first is the pseudomembranous candidiasis, are also known as oral thrush. This is the acute pseudomembranous candidiasis or oral thrush. In oral thrush or acute pseudomembranous candidiasis, there is a creamy light adherent plaque or erythematous oral mucosa, usually on cheek, palate or oropharynx. Here there is an oropharynx. Can be easily whipped up. The difference between lichen planus and oral candidiasis is that in lichen planus the white patches is not whipped up, but in oral candidiasis the white patches is whipped up. When we use a tongue blade to remove these white patches, it will be removed. Commonly seen in HIV patients. Immune deficiency virus patient, immune virus patient mean AIDS. Why? Due to decreased immunity, because it is opportunistic infection. This is the acute pseudomembranous candidiasis. Due to tongue blade, we can whip up these white patches, and this is also known as oral thrush. Now come to the second type, which is erythematous candidiasis. This is the erythematous candidiasis. In erythematous candidiasis, there is a red shiny atrophic appearance. There is atrophy and there is a red shiny appearance. Now come to the next in chronic types. First is the chronic atrophic candidiasis, also known as denture stomatitis, are also known as denture-induced stomatitis. In denture-induced stomatitis, there is prompted by ill-fitting denture. When denture is not fit, ill-fitting denture cause denture-induced stomatitis. And poor denture hygiene, wearing up denture at night. If there is a poor denture hygiene, if there is ill-fitting denture, and if a patient wear denture at night, in the result there will be denture-induced stomatitis, because a patient should not wear denture at night. In order to, there is a rest for the mucosa from 6 to 8 weeks. And enclosed mucosa is cut from protective action of saliva. Mean the enclosed mucosa is cut from protective action of saliva. Mucosal erythema restricted to area covered by denture. Mean mucosal erythema restricted to that area which covered by denture. Next is the acute antibiotic stomatitis. This is a condition which occurs due to overuse of antibiotics, especially tetracycline, suppressing normal oral mucosa. Whole mucosa is red and sore. This is the difference between denture-induced stomatitis and acute antibiotic stomatitis is that in denture-induced stomatitis is the mucosal erythema restricted to area covered by denture, only that area covered by denture. But in acute antibiotic stomatitis, whole mucosa is red and sore, and it is occurred due to overuse of antibiotics, especially tetracycline. Now come to the next type, which is the angular cheilitis, are also known as angular cheilitis. In angular cheilitis, this is the angular cheilitis. On the corner of the mouth, there is a lesion. There are some sore each angle of the mouth. In angular cheilitis, in denture-wearing patient, it is caused by infection with Candida species. In denture-wearing patient, it is caused by infection with Candida species. Iron deficiency is a significant etiology in angular cheilitis. Without denture, it is most likely to be caused by infection with Streptococcus species or Staphylococcus species. If patient wear denture and there is a lesion on the corner of the mouth, this is due to Candida albicans and due to Candida species. If a patient is not denture wearer, then it is caused by Streptococcus species or Staphylococcus species. Unless if there is no Staph aureus bacteria are present which cause skin infection, treatment should be commenced with azole, mean fluconazole or ketoconazole, these drugs. Mean if Streptococcus aureus is not associated, mean if bacteria is not associated, then we go for antifungal drug which is azole. Now come to the next is the median rhomboid glossitis. Glossitis is inflammation of tongue. Median mean mid-region, rhomboid glossitis. In median rhomboid glossitis, this is the next type. Here, median rhomboid glossitis. In median rhomboid glossitis, seen in patient using inhaled steroids and smoker. Mean if patient is smoker or they inhale steroids, there will be median rhomboid glossitis. Lesion are in center of dorsum of tongue and palate, which is also known as kissing lesion. Lozenge shape erythematous patch on the midline dorsal tongue. Histopathology show epithelial hyperplasia with neutrophil in parakeratin layer. Next is the chronic hyperplastic candidiasis, are also known as Candida leukoplakia. Chronic hyperplastic candidiasis are also known as Candida leukoplakia on third number. In chronic hyperplastic candidiasis, white patches on the oral, commissural, buccal mucosa bilaterally or dorsum of tongue. There is an increased risk of malignant changes mean the chronic hyperplastic candidiasis. The MCQs come, which type of candidiasis have increased risk of malignant changes? This is a chronic hyperplasia, hyperplastic candidiasis. Histopathology show candidial hyphae can be seen in the superficial layer of the epidermis. There is a blunt retipex and neutrophils form micro abscesses in parakeratin. Now come to the last part, which is a treatment. In treatment, first we give local Mayer. Advise patient who use corticosteroid inhaler to rinse their mouth with water or brush teeth immediately after using the inhaler. Fluconazole capsule 50 mg first 1 capsule per 7 days. Mean first they use local Mayer. Mean advise patient who use corticosteroid to rinse their mouth with water or brush teeth immediately after using the inhaler. And we give fluconazole capsule 50 mg 1 capsule daily per 7 days. Means 7 capsule per 7 days. Do not prescribe azole per patient taking warfarin or statin. A patient taking warfarin and statin, do not prescribe azole. Our other treatment is miconazole oro mucosal gel 24 mg per ml we give in the tube, which is 80 gram. Apply pea-size amount after food 4 times daily. Mean after food apply pea-size amount 4 times daily. Advise patient to continue use for 48 hours after lesion have healed. If azole are contraindicated, then we give nystatin oral suspension 1 lakh unit per ml, 1 ml after food 4 times daily per 7 days. Mean this is the treatment. Now in last time in NLE MCQs, the MCQs was come which type of drug we give in oral candidiasis. In option the nystatin is mentioned, we take the nystatin. Now this is the treatment. Mean first we give local Mayer and fluconazole, and then this is one treatment. Or we can give miconazole gel, and if azole is contraindicated, then we give nystatin oral suspension. This is all about today's topic. In next video we will discuss next topic. If you like my video, press the like button and share this video with your friends. If you are new to my channel, subscribe my channel by pressing the red subscribe button, and also press the bell icon in order to receive my each new video notification. For watching my videos, I am very thankful to you. Thank you very much.